Welcome to the GMJ podcast, the official podcast of the Georgian Medical Journal.
In this series, we present structured discussions of peer-reviewed contributions published in GMJ, examining their implications for clinical practice, medical education, and health policy.
Each episode offers a focused, analytical review intended for researchers, clinicians, academic faculty, and healthcare leaders seeking clarity and evidence-informed reflection.
This episode reviews the article titled, Commentary Patient-Centered Care and Professionalism in Medical Facilities. Implications for Medical Education, Communication, and Empathy. Why Patient-Centered Care Remains Incompletely Realized.
And before we really get into this deep dive, we should quickly establish the foundational context of this work. It's a collaborative piece by a very strong team of authors.
Right, you have Professor Irene Kakadze from Akaki Tsereteli State University, who brings this crucial perspective as an affiliate expert of Accreditation Canada.
And Professor Tamar Telekvadze from David Chiliani Medical University, also a deputy representative of Accreditation Canada.
Exactly. Along with Professor Georgi Kakadze, the editor-in-chief of GMJ. So you have this blend of deep academic insight and very practical, boots-on-the-ground accreditation experience.
Which is vital for this topic. And for those of you looking to pull up the source material, this is published in the Georgian Medical Journal, Volume 2025, Number 1.
And the DOI is 10.5281 Zenido.18109374.
So, getting to the central question of this article, the authors are tackling a very stark paradox regarding patient-centered care, or PCC.
Yeah, the paradox of, well, the fact that it's essentially everywhere in theory, but distinctly lacking in practice.
Exactly. I mean, we've had 2 decades of international consensus. The World Health Organization, the Institute of Medicine, they've all made this a primary directive. It is embedded in virtually every hospital's strategic plan.
But the reality on the ward, it remains, as the title so carefully put it, incompletely realized.
Incompletely realized. It's a very measured way of saying we are failing at this on a daily basis. And what's fascinating is the author's core thesis on why we are failing.
Right, because the instinct is usually to blame the clinician, isn't it? To say, oh, the doctors just need more empathy training, or we need better clinical knowledge, or more advanced technology.
But the authors completely reject that premise. They state clearly that the gap between policy and practice is absolutely not due to a lack of clinical competence.
It is a structural failure. They point to 3 specific systemic weaknesses: professional culture, medical education models, and organizational accountability frameworks.
So it's the environment, not the individual. Let's clarify this conceptual background a bit, specifically looking at the context of reform, particularly in Georgia.
The Georgian context is really useful here as a lens. You have a healthcare system undergoing significant reform. And in these transitional phases, you often see what the authors describe as an aspirational gap.
Where the language of accreditation and policy is perfectly aligned with international standards.
But the routine patient experience hasn't shifted. Because you can mandate a process, but you can't mandate a culture through a memo.
Right. And that brings us to how they define professionalism. This is probably one of the most significant conceptual shifts in the paper.
It really is. Traditionally, for most of us, professionalism is viewed as this purely individual attribute. It's your personal ethics. Are you polite? Are you punctual? Do you care?
A sort of moral scorecard for the individual physician.
Exactly. But the authors argue that this modern definition needs to shift. Professionalism must be understood as a collective and organizational function.
Meaning the institution itself has to be professional. It has to have accountability, integrity, and an actual responsiveness to patient values built into its operating system.
Because if those organizational functions aren't there, patient-centered care just becomes procedural.
Procedural care. That's a great term. You check the box that says you ask the patient about their concerns, but you don't actually have the systemic support to address those concerns.
Which is incredibly frustrating for both the patient and the clinician. And this leads right into the main findings regarding what they call systemic determinants.
The environmental factors that actually shape how professionals behave on a Tuesday at 3 in the afternoon.
Right, and they identify specific drivers: leadership behavior, governance structures, workload design, and institutional incentives.
Let's talk about workload design because that is such a tangible barrier. When you have high clinical workloads and severe staffing constraints, what happens to empathy?
It evaporates. The authors describe this as the erosion of ethics.
The erosion of ethics. That sounds severe, but it makes complete sense.
It does, because if you don't have an environment that provides psychological safety, if a clinician is forced to see 40 patients in a shift, They're essentially forced into survival mode.
And the article uses very specific descriptors for this behavior. They say interactions become defensive, task-oriented, or minimalistic.
Minimalistic. You stop treating the human being and you start treating the task.
Yes.
You check the vitals, you write the script, you move on.
And again, to reiterate their core argument, we cannot view this minimalistic interaction as a moral failing of that specific doctor.
No, the system demands that behavior. If there are no feedback mechanisms, and if leadership incentivizes throughput over connection, defensive medicine becomes the norm.
So professionalism is really the essential substrate of patient-centered care. If the soil is toxic, the care cannot grow beyond just an aspirational intent.
Which brings us to perhaps the most insidious way this toxic soil is maintained, and that's through medical education.
Yes. The structural analysis of education here is brilliant. They bring in this concept of the hidden curriculum, citing Hafferty.
For those navigating medical education, the hidden curriculum is a very familiar, often frustrating reality. It's the disconnect between formal education and the actual clinical environment.
Right, because you sit in a lecture hall and you are formally taught all the pillars of patient-centered care. Active listening, empathy, shared decision-making.
But then you step onto the ward for your clinical rotations. And learners acquire their professional norms not from a PowerPoint slide, but through informal and experiential processes.
Observational learning. This is huge in the Georgian context they describe, but really, it's a universal phenomenon in medicine.
Absolutely. Medical learners shape their professional identity by watching senior clinicians.
So if a student is taught empathy in the morning, but in the afternoon they watch an attending physician speak rudely to a nurse, or rush through a difficult diagnosis without looking the patient in the eye.
They internalize the behavior they witness. The lived reality always overrides the theoretical instruction.
It normalizes these practices. The student learns that to survive and succeed in this specific hospital, you have to be fast and detached, regardless of what the textbook says.
And the mechanisms of this identity formation are entirely structural. It's the role modeling by physicians and nurses, it's the bedside teaching, it's the real-time exposure to ethical or unethical decisions.
So we have this pipeline of new doctors who are essentially being trained by the environment to abandon patient-centered care.
Which has massive implications. And this is where the commentary gets very analytical about the consequences, specifically regarding communication.
Because there is a very persistent myth in medicine that communication and empathy are just, well, soft skills. Nice to have, but not essential like surgical technique.
The authors completely refute that. They frame communication and empathy as safety-critical competencies.
Safety critical. That puts communication on the exact same level as infection control or correct medication dosing.
And the evidence they cite supports this entirely. When communication fails, when interactions are task-oriented and minimalistic, you see a direct link to adverse events.
Because the patient loses trust. And when a patient doesn't trust the clinician, they might withhold critical medical history.
Or they don't understand the discharge instructions, which leads to treatment non-adherence. They take the wrong dose, or they don't show up for follow-up care.
So a compromised care quality is directly tied to a lack of empathy. It's not just about the patient feeling good, it's about the patient staying safe.
And taking that systemic view, these communication failures are rarely just one doctor making an isolated error. They are manifestations of a hierarchical culture.
A culture with inadequate feedback loops. If a senior doctor communicates poorly, but the hierarchy prevents anyone from correcting them, that risk factor remains in the system permanently. So, moving into the system-level reflection portion of the article, how do we actually address this? The authors are very clear that we need to stop shifting responsibility onto the individual.
Right. You cannot expect professional behavior from individuals if you do not provide the institutional conditions to sustain it.
It's an unfair expectation. You're asking someone to swim upstream all day, every day.
Exactly. So they propose what they call a quality ecosystem. This requires an alignment between three major pillars of the healthcare structure.
Let's break those down. The first pillar is medical education.
But not just adding another lecture on empathy, they emphasize continuous faculty development and reflective practice.
Meaning you have to train the teachers. The senior clinicians need to be acutely aware of the hidden curriculum they are projecting.
The second pillar is clinical governance. This is about leadership, accountability, and support.
So hospital administrators and medical directors have to actually build systems, manageable workloads, adequate staffing that allow time for empathy.
They have to support their staff.
Yeah.
And then the third pillar, which ties it all together, is accreditation systems.
And here the authors caution against symbolic compliance.
Yes. Having a beautiful policy document on patient-centered care sitting in a binder for the accreditation surveyors is not enough.
The accreditation has to move beyond checking boxes to measuring actual behavioral standards on the floor.
And this is where the authors see a significant opportunity for Georgia. With the system currently undergoing reform, there is a chance to align these three pillars right now.
To build an ecosystem where medical education, clinical governance, and accreditation are all mutually reinforcing the exact same behavioral standards.
It's a profound structural challenge, but it's the only way to move patient-centered care from policy to reality.
Which brings us to the core summary of this analysis. The central thesis, delivered in very measured language, is that patient-centered care fails when professionalism is treated as an individual moral obligation.
It fails because the system will always overpower the individual.
But it can succeed if we recognize professionalism as a shared organizational responsibility. Sustainable care requires an integrated ecosystem where faculty development and leadership accountability ensure that professional values are visibly enacted, not just taught.
The environment has to match the expectation.
Exactly. And as you consider how this applies to your own institution or practice, it raises a rather provocative question. We spend immense resources auditing financial compliance and clinical outcomes, but how thoroughly are we auditing the psychological safety of our clinical environments, which this article proves is the actual foundation of patient safety? It is something that every healthcare leader needs to deeply evaluate.
Thank you for listening to the GMJ Podcast.
For a full and detailed discussion of the topic presented in this episode, we invite you to consult the original article published in the Georgian Medical Journal.
The article is available at gmj.ge, and a direct link is provided in the episode description.
We look forward to continuing these scholarly discussions in future episodes.